Can you hear me now? No? Let's see. I'm going to try to change my settings. All right. Is this better? Still nothing? Hey, can you hear me? Testing. I can't hear you now. Can you hear me? Okay, but I can't hear you.
Can you hear me now?
Yes.
Okay, good.
All right. I had so many options for microphones. Hard to know which one to choose.
Yeah, my good camera is suddenly unavailable, so I don't know. Anyway, we're okay.
Good to see you.
Yeah, you too.
Yeah.
How have things been? Are you still involved with the convention center?
Not day to day, not so much anymore.
Yeah.
I was more involved in the hotel, so
yeah.
Eager to hear some updates.
Yeah, there's a lot of work that you all put into that for sure.
Oh my gosh. Well, we'll see. The winter is coming, so we'll know if we still need it.
Yeah. There's some interesting things that they're doing with the Mayor's Office of Homeless Services just to. Hi, Janaki. Nice to meet you.
Hi.
Good to see you.
Nice to meet you too. I was going to go and just finish up with the patient and have you all start. Is that okay, Alex?
Yeah, that's fine with me. Is
that fine with you, Marek?
Sure.
Lori, it's...
Yeah, okay.
I don't think it's joined yet.
Yeah.
Okay. I'll be right back.
Okay.
It is you, ma'am. Thank you.
It looks like people are still joining the session. I just got a message from Lori that said I can't get in with my audio or video, but she is in the session. Let's see. Okay. Looks like Lori's having some trouble with her connection.
Oh no.
I'm texting her just to see if she wants me to start or if there's. I think she was going to do an introduction.
I'm going to mute Janaki if I can. Yep.
Yeah. just waiting for Lori to reply. And I think we are live, right? Hopefully.
Yep, I think so.
Okay. Looks like she's typing.
Oh, good.
Okay. All right. I'll just start sharing my slides and I'll just jump into it.
Okay.
Let's see. Okay. Are you seeing the title slide? Okay. All right. So thank you all, everyone who's here, for joining us. I wish I could join with the rest of the sessions, which look really interesting, but I'm kind of in between clinical activities. But it's a pleasure to join the panelists and our audience today. And just a quick intro, I am a primary care physician, specifically in the field of family medicine. My position is within the University of Maryland School of Medicine, and I provide clinical care and I teach in the Department of Family and Community Medicine in the residency program. I also serve as the medical director of the teaching practice in downtown Baltimore, which sees over about 20,000 patients annually. And just wanted to start with a overall timeline to give us both a global and a local perspective of where we've been with COVID-19. And it seems like a lifetime, but we're still less than a year from the first identified case of COVID-19 in China. In early March, the state of Maryland recorded its first case of COVID. And a few days later, the WHO declared this disease a global pandemic. Around this time, the leadership of the University of Maryland Medical System, which is a 13-hospital system throughout the state, partnered with that of Johns Hopkins Medicine and the state of Maryland to begin setting up a field medical station at the Baltimore Convention Center that later became the Baltimore City Convention Center Field Hospital and is still in operation. Shortly afterwards, Dr. Sunta, who's our CEO of the UMMS system and the as we call it, the Incident Command, decided to add an additional alternate care site by converting a city hotel, the Lord Baltimore, which you'll hear much more about from Dr. Moen. This was done in order to try to decant the anticipated surge of patients from both UMMC, the University of Maryland Medical Center, hospitals in downtown and midtown. And this was with the understanding that a surge may result in capacity, the demand surpassing the available bed capacity. It was around that time in March that I was asked to join the team setting up the alternate care site at the hotel as the CMO of the task force. And it was with a group of some really excellent clinical and administrative leaders from around the health system of the University of Maryland. And soon after our blueprint for a clinical ACS site, the alternate care site, was completed, both the UMMS health system and the city health department priorities made it clear that the greatest need was not in hospital capacity, as we actually had decent number of beds available, but it was rather in the isolation space, especially for the city's most vulnerable residents. So why the concern for isolation space? And I want to delve into this a little bit more. This map that you're seeing shows the community vulnerability to COVID-19. And as you can see, some communities are definitely more vulnerable than others, meaning that they have a limited ability to mitigate, treat, and delay transmission of a pandemic disease, and also to reduce its economic and social impacts. So the COVID-19 Community Vulnerability Index, or CCVI, is one tool that we use which identifies these communities within the context of the COVID-19 pandemic. So this index, it combines indicators that are specific to COVID-19 with the CDC's Social Vulnerability Index, which has been used previous to COVID-19. And it measures the expected negative impact of any type of disaster on the community. So these indicators are grouped into 6 themes, specifically the socioeconomic status, minority status and language, housing type and transportation, public transportation, household composition and disability, epidemiological factors, and healthcare system factors, such as access to services. And an overall CCVI score is then generated at the census tract, at the county, or at the state levels. And in this model, a higher score, which would be closer to 1, indicates greater vulnerability of the community to the ill effects of the pandemic in this case. So the CCVI is not designed to predict which individuals will become infected with coronavirus. Instead, it tells us about the anticipated negative impact at the community level. So it helps decision makers target resources where they are needed most. And as you can see, the index can vary greatly when examining indicators at various levels, such as the state, city, and community. From our system down to the practice level, we are especially concerned about our most vulnerable populations, such as individuals and families with unstable housing or staying in congregate housing, where there's a very limited ability to quarantine or practice social distancing. And in the map, you could see that at the community level, we have some communities in Baltimore, such as West Baltimore neighborhoods, where the index is almost 1, meaning that on all measures of vulnerability that they score extremely high. And to demonstrate how local disparities in Baltimore shape the health and socioeconomic outcomes in our city, we can look at data from the health department. So let's compare a neighborhood in West Baltimore, such as you can see in the slide, the Poppleton Hollins Market, and where many of my practice's patients live. And we can compare that to the city as a whole. So you can see some of the stark differences in demographic and economic indicators between this neighborhood cluster and the average citywide statistics. Those of us who work in Baltimore's health sector will recognize the stark disparities among neighborhoods, and that is a byproduct of many decades of structural racism and the surrounding effects. This includes former real estate practices such as blockbusting and redlining that have sort of concentrated poverty in small clusters. And as a department, family and community medicine provides healthcare services to about 35,000 patients each year. And since the start of the pandemic, we've been offering COVID-19 testing, evaluation, and follow-up care to thousands of our patients. And this effort has thus far identified about 500 community members infected with SARS-CoV-2 from across our 3 sites, including downtown Baltimore and Columbia, Maryland. And this slide shows one of the tracking tools that we've developed and we use regularly. And it's part of a dashboard that is updated daily, thanks to the hard work of Drs. Klushenkova and Dr. Khanna. And we do this as a department in order to understand the epidemiology, as well as to use real-time data to prepare and respond to a potential second wave. And it also helps us to calculate the PPE, the personal protective equipment, the cleaning supplies, and other stock and inventory items that we need to be prepared for the week ahead. The shaded regions in this map correspond with something known as the Area Deprivation Index, the ADI, and also is another tool that we use to rank neighborhoods by socioeconomic disadvantage. And it includes factors for the domains of income, education, employment, and housing quality. So the ADI has been applied in other settings, and it can be used to inform health services delivery and policy. And we do use it to study the racial disparities of this pandemic as well. And you can see the color-coded indicators of where our patients who are infected with COVID are coming from. And as you can see, it disproportionately affecting minority groups, which is something that has been widely reported by now, especially African Americans and Hispanics. not just in Baltimore, but all over the country. And the situation was and likely remains precarious in the city's congregate housing locations, especially homeless shelters. You can imagine how difficult it would be to maintain distancing and, as I mentioned earlier, keeping people with symptoms in quarantine when you're forced to live in crowded quarters such as this. So when I was involved with the alternate care site project, we were getting informal reports from our colleagues at the health department documenting that there was a range of 15 to 50% infection rate in Baltimore City homeless shelters based on sample data that they were collecting between March and April. All right, so shifting gears a bit, I'd like to provide a brief overview of how this pandemic has affected the primary care providers who really form the bedrock of any healthcare system. And if you visited a healthcare facility lately, you will know that the idea of the waiting room has been completely transformed. The reality of coming to your doctor's office for a checkup now involves strict and often multi-step screening procedures. Careful crowd control and distancing requires limited occupancy in these facilities. And some practices have severely restricted their appointment availability because of difficulties getting PPE supplies and cleaning products, or just the constraints of their physical indoor space. In some practices, parking lots have even been used as waiting rooms with people sitting in their cars until they're ready to be seen. But unfortunately, practices such as my own, where there's a lack of parking facilities, those options are restricted. And the rigorous disinfection procedures also limit the number of patients who can be seen on any given day. So many clinics were never designed to accommodate the infection prevention measures that we're now required to observe. And the result has been quite devastating for many practices, especially smaller providers who have had to make some very painful decisions, including laying off staff, cutting services, or even permanently shutting their doors. And you can see that in this early tracking period in March, April, up to May, there was visits to ambulatory practices declined by about 60%. And a rebound is occurring, but the number of visits is still far below what we've been seeing pre-pandemic. And the trend is similar all over the country, but as you can see, the New England, Mid-Atlantic region was hit particularly hard, and that recovery is lagging behind other parts of the country. And especially, I do want to point out that you have primary care practices in rural and other underserved areas that are struggling even harder to retain their staff and provide services. And with their financial revenue models not really equipped to sustain this prolonged period of decline, it's really taken a blow. Modeling through the end of June illustrates the potential economic impact of primary care practice closures across the country, and some predictions report that 60,000 primary care providers and nearly 800,000 jobs are at risk. Factoring in nurse practitioners, physician's assistants, those numbers may look even worse if this stretches far into 2021. So all this has the potential to reduce access to essential healthcare and worsen already existing health disparities, with minorities and people of color suffering the lion's share. Now, this graph illustrates the rapid adoption of telehealth, which has been one of the few positive developments made possible by emergency authorizations issued by federal and state health authorities. And remember that prior to COVID-19, many geographic and financial restrictions largely prevented widespread use of telehealth. So while this technology has allowed people to more easily connect with their primary care providers, it is also not as accessible to people of lower socioeconomic status, given the disparities in internet access and smartphone ownership. So we do need to continue to devote our attention as a society to address this gap in connectivity. And these are just some examples of telehealth that can be found both on the inpatient as well as outpatient areas. Platforms such as Zoom, Doximity, and Doxy.me. And the old-fashioned telephone, or the audio-only method, as we call it, allows us to offer our patients the option which is most suitable and accessible to them. So that is what we as a practice strive to do. A lot of progress is also being made to make widespread use of remote patient monitoring. This is not only for COVID-19, but has great potential to be used to improve chronic care management in general, whereby people can measure everything, biometrics such as weight, temperature, blood pressure, heart rate, blood sugar, and other things using technology such as apps, and then transmit that data to the health facility, which often has integrated electronic health records, as we do. And such information can be used in real time to identify patients in need of immediate intervention for things such as heart failure exacerbation or uncontrolled or unstable heart hypertension and diabetes. And with more support to help us expand this technology, this can significantly reduce our hospitalization and emergency department rates, and most importantly, keeping our patients healthier and at home. Lastly, health system financing models will need to be reevaluated, as the longstanding fee-for-service system, as myself and many of my colleagues will attest, is fatally flawed, even in the best of times. Fee-for-service rewards providers basically for the quantity of services that they provide rather than the quality. And the limitations imposed by COVID-19 make this model really incompatible with long-term financial stability. So many experts have put forward proposals to shift even faster towards value-based care and capitation models that provide fees to practices for the care of populations. And while this was already taking place, many of us are hoping the pandemic offers policymakers an opportunity to accelerate this at a larger scale. And I think that will protect our primary care infrastructure and the communities that we serve, as long as adequate support is provided along that. And just some pictures to share from our dedicated and vibrant staff and clinicians at the University Family Medicine. And I thank you all for this opportunity to speak, and we'll be happy to take questions later.
Good morning, everyone. I'm Lori Edwards, and I'm the late moderator to the session. I had some technology issues, and so I wanted to just thank you, Dr. Kaysen, for that incredibly interesting presentation. And there is one question now, and I'll just check in with you on this. Would you be willing to share your slides?
Sure.
Okay, I can forward those to the organizers of this event for that to happen. So anyway, thank you very much. And again, questions will be held later. And I'm really grateful to be with these three esteemed colleagues of mine. And I will now ask Dr. Deepak to share her experiences on the front lines. Thank you. I think you're muted.
Should be unmuted now. Oh, yeah. Oh, no, that's not her. Oh, no, that's not her.
Do you see the little microphone on the bottom? I think we could hear you before, so it might be something on the, maybe there was a mute button that was pressed. We might have to log in again to share audio or video again. So Our organizer says you should be able to select this audio icon on the bottom of your screen. I don't know if you, when you select that, if you're, sorry everyone who's hearing us struggle through these technology things. Okay. Marique, would you, Dr. Moen, would you
Sure.
be willing to share?
Is my camera going in and out for you? I'm afraid I'm.
Yes.
Yeah, okay.
Yeah.
Hold on. Quick fix.
Can you hear me now?
Oh, yes, we can.
Okay, perfect. Okay. All good still?
We're good.
Okay, perfect. Okay.
We lost you again. Do you want me to proceed, or I think she's back?
Can you hear me now?
Yes.
Yes. Okay, I'm not going to touch anything and I'm going to start speaking so that I don't lose anybody. Thanks. Thank you for giving me the chance for speaking today. I don't have any slides to share. I have quite a few stories to share. It's been a very interesting experience, really on the front lines, on the dying front lines, if you will, of COVID, seeing the sickest patients of COVID being, I am a pulmonary and critical care physician, so I have seen the sickest of the sick with COVID. Almost every single one of us, me and my colleagues, have also faced the sense of mortality almost. So I will start with our first experience. So the first patient that we saw in our medical center was on the 14th of March, and I was on that weekend. The patient was flown in from Bhutan, very sick patient, had flown 32 hours, come in, and it was in, at that time, nobody knew what was the right thing, what is the wrong thing, came in with so many papers, medical records. We couldn't get the medical records out of the room. Patient was struggling on the ventilator. The patient was on a completely different floor. We went back down there, spent 2 hours in the patient's airway, taking out what seemed like almost concretions, like stone-like structures, secretions that had just impacted in those airways. And then to find out the next day that apparently you're not supposed to do bronchoscopy in patients with COVID, as it's the most aerosolizing procedure that you can think of. And I spent 2 hours down that patient's airway that day, and I do have severe asthma. And did I get some flack for it? Yes, I did. But the next day, the patient came off the ventilator and in 7 days, the patient left the hospital and was in rehab, and a month later was at home. So it helped the patient, definitely helped the patient. But that was just the beginning. We saw in a month, we saw patients just pouring in. Every day was a different set of how we were going to manage the patients, what was the new protocol. There was no sense. The medications were changing day by day, not even week by week. It was day by day. Everything was on a trial basis. We were getting the biggest problem was, one, there was no directive on the medicines initially. Two, families were not at the bedside. So to take care of patients who are critically ill and not have families at the bedside, and not be able to connect with them is the most helpless thing for an ICU doctor, because you are not able to connect with families. You're not able to form that rapport with them. You're not able to tell them. And there's only so much that iPad or technology can really do, right? We can only do so much. We can only talk so much. We cannot. And then we were having 3 patients in a room at one time because there was no place to put the patients, because there were so many patients who were getting sick. We saw really healthy people who had no real medical condition die from COVID. But we saw some people with many, many sicknesses, and we thought those were the ones who had to die from COVID, did not die, actually got better from COVID. Until today, we don't have a good understanding on who really dies from COVID. We do know that people who are older, people who have certain medical conditions are more likely to get COVID. And yes, they are more likely to die. But actually, things like lack of social distancing, poorer socioeconomic status, certain demographics, the Hispanic population got really, really badly hit. Most of our ICU was filled with Hispanic population. It was so difficult because there was a language barrier. We could not really communicate. There was only so much of interpretation that we could do. We were not able to talk to the families effectively a lot of times. We had interpreters, but every single thing that we were saying was not getting communicated. And people, no matter what we did, were dying. And everybody was in a state of panic, right? So it is not just that the families were in a state of feeling not good, but a lot of doctors from different specialties were not feeling that comfortable in even going in, even with all their special precautions, because this was not something everyone was scared in the initial phases. And there was only the beauty of it was there was a lot of it we could do with the iPads, but there were only a bunch of us who were actually at the bedside taking care of patients. So from March 14th to nearly end of August, the division of pulmonary critical care, there were about 25 of us. We were nearly continuously in taking care of COVID patients for the whole time. So all of us were pulling in about 3 or 4 weekends every month, and we had not really seen sunshine or taken a break and had any kind of real any changes or done anything. So what kind of impact has it had on our lives? One, every single one of us, including right now, all of us face the feeling that we still not seen the end of it, right? We still feel that COVID is coming along with influenza now, and it is going to come, and it is going to be even more difficult because November, December, January, February is always difficult times for ICU doctors because that's when influenza comes, and influenza plus COVID is a very, very difficult time. The big things are social distancing is not a myth. This is not a conspiracy theory. This is really a virus. This is a virus which has been there. SARS-CoV-1 caused similar things, not as bad. MERS-CoV did it, not as bad as this. And this is the third one. It is in the same subset of viruses. So this is not a conspiracy theory. This is much more than the other viruses of its own species, yes, but this is not a conspiracy theory. It causes really bad reactions. So what it does almost is it almost makes your body's immune cells to kind of rev up. And that is what causes the multi-organ failure in many ways that we are seeing in this subset of patients. And when we see that there are not too many things in our armamentarium that we have till now, what we do have right now as of October 9th, 2020 is we have dexamethasone, which is a steroid, which we know in the initial phases calms it down when given for 10 days. Calms it down. It calms down that inflammatory response, that immune response. We know that remdesivir, when given early, decreases the virus replication. And maybe convalescent plasma helps a little bit. The antibodies that the president got, one, that's not available to everyone, and two, we really do not have studies for it. We do not have science behind it. Hydroxychloroquine killed people. My most horrific patient of it was a young 32-year-old who had gotten hydroxychloroquine at an outside hospital, came to us, and she died not because of COVID, but because of the complications of hydroxychloroquine on the heart. So there are problems with these drugs. Now, remember when the HIV pandemic, not the pandemic, when the HIV epidemic hit way back then, we did not know anything about it, right? There was a lot of theories about it. There was the same kind of fear. There was the same kind of feeling. There was all these voodoo WhatsApp things that were going on, fake news that were going on. Now we know so much about it. Now we are able to cure HIV. Similarly, one day we are going to be able to cure COVID. We are in the brink of one of the biggest pandemics that we have ever seen. We've got to give it time, but we have to let science let it do what it takes. It takes time for any scientific study to happen. It doesn't happen in days. It doesn't happen in minutes. And one medicine doesn't work for all. One medicine never works for all. There are different populations that medications work for. So it's not the same medicine for all. Vaccines are not a magic pill. Vaccines don't happen immediately. So it is still killing people all over the world. I'm constantly on the phone with my parents in India. We are seeing a lot of death in India, a lot of death. I'm from Mumbai in India, and there are a lot of people dying of COVID in India. So it is still killing people. It will continue to kill people because it sets up this almost immune response in your body. It's the thing that it's meant to do, right? So body is meant to have an immune response, except it's almost like an overactive immune response. And there is uncontrolled immune response. And there is nothing we can do to kind of shut it down. And then you get other infections. So there is a lot going on with COVID that we still don't know. But what we do know is masks save lives. They do save lives. Social distancing saves lives. These are the most, and cleaning hands absolutely saves lives. That we knew even before COVID. It prevents all kinds of infections. Hand hygiene was everything. So these things are easy for us to do. COVID spread is in the hands of each and every person. Yes, we are in the front line. Yes, we are helping, but you guys are empowered to do much more to stop COVID than what we are able to do. You can actually stop the spread of COVID more than we can do. That's all I got.
That was amazing and wonderful. And I thank you, Dr. Deepak. I think all of us applaud you for that amazing work that you're doing truly on the front lines. But also, I hope for you that you get some time off in the near future to restore and prepare for the next round. So thank you. And we'll have time for questions, hopefully, at the end. Thank you. Dr. Moen, could you share your experience now? We can't hear you. Oh, no.
Can you hear me now? Okay, good. All right. I just wanted to say thank you, Dr. Case and Dr. Deepak. It's tough acts to follow. I'm sharing in the comments an article by a quasi-colleague, Dr. Kathleen Page, over at Johns Hopkins, and her colleague from the Baltimore City Health Department, just following up on the, as we're focusing on communities who are impacted, on the Latinx community, as Dr. Deepak mentioned, and how it didn't have to be this way, and the consequences and sequelae of policies, and how certain communities became disproportionately infected and affected, and then their lives were lost. So I just wanted to follow up on that, and thank you for bringing attention to that community. I am going to share my experience. I hope you are seeing my experience here. Are you seeing my my slides? I can't hear. Yes? Okay. One moment. Okay, this is me in front of elevators with my Baltimore City Health Department colleagues, Dr. Amanda Rosecrans and nurse practitioner Bobby Harris, Dr. Kevin Burns, who's also a colleague of Alex in family medicine, and nurse Vanessa Augustine. And we were the leadership team for the Baltimore City Lord Baltimore Triage Respite and Isolation Center at the Lord Baltimore Hotel. So the Triage Respite and Isolation Center picked up where Alex and the University of Maryland's team left off. The city, as Alex said, and recognized that the need was not for more hospital beds, but for isolation sites. And they quickly realized that the two Baltimore City healthcare providers who were seeing hundreds of patients in isolation hotels that had been set up when the shelters began to experience outbreaks needed more support. And so partnered with the city and the Lord Baltimore Hotel, who was, I believe, the only hotel in the city who stepped up to say yes. And they transferred the residents from the shelters who had been out at remote motels into the Baltimore City Lord Baltimore location. And with my colleagues, we mounted the first ever isolation hotel in Maryland and Baltimore City. Since then, there's others that have developed. The hotel had 24-hour nursing staff with providers on site for most of the time, and overnight they were on call. And I'm going to share a little bit about the stats, but I really hope to be able to answer some questions and get into a dialogue. So it's also unique in that it was led by the Baltimore City's mayor's office, especially the mayor's office of homeless services and the health department, and the medical system was the clinical partner. So it was a innovative partnership as well. There are isolation sites throughout the country, and they are each unique, but I think this is a really exemplary a partnership. I went back to my regular duties at the School of Nursing in September. So the numbers that I'm going to share with you end in August, but the hotel is still in operation. And the reason that I was kind of pulled into it, having no experience leading isolation hotels, is because of my experience serving persons living with HIV in particular, and people experiencing homelessness, substance use, and mental health issues. The hotel is open to all individuals, but some communities are disproportionately impacted. So up to the end of August, there was about 426 and residents that that stayed at the hotel. They were residents because they were not patients. They were not sick enough to require medical care. If they did, that's why we had the 24-hour medical support on site. We could quickly transfer them and triage them to a higher level of care. To date, I believe they have served 600. They were at over 550 at the end of September. Average length of stay was 7.5 days, and that's because some were persons under investigation, so not all of them were isolating for the recommended 10 days. And more men than women. The average age of the men was older than the women, and you can see kind of the breakdown is kind of mirrors what the epidemic has done, and that it is disproportionately affecting older persons. You also see that we had a disproportionate number of Black or African American residents and Hispanic persons relative to the city demographics per the Census Bureau, which also mirrors how the epidemic has impacted some communities disproportionately nationwide, and especially in our city. Most of the residents were coming from, initially it was from shelter settings, and then we would get direct referrals of persons who might go to clinics or healthcare for the homeless, and they have unstable housing. And while they were waiting for results, because they often might need a test result to get into shelter if that was available, they would come to isolate or quarantine at the hotel. And then I think the testament to the success of the hotel is that the greatest proportion of residents came from community members, people on the street who said, hey, my brother needs a place to isolate, he can't stay here, grandma has a trach, can we refer a relative here? So we unfortunately had kind of serial admissions from congregate housing settings, as you can imagine. And so that what that means is that whether for substance use or shelter, those locations are now offline because they have to transfer their residents to the Baltimore Hotel to either quarantine or isolate while they try to regroup. And then the residents from the community, we had also during a certain period of time, majority of residents who were from the Latinx community. But unfortunately, just to be transparent, I don't feel that we satisfactorily were able to engage the Latinx community, given the disproportionate impact for various reasons. Just to pursue that note a little bit, that the location was right near the ICE facility. And I've also heard, as Dr. Page states in her article in the New England Journal, that when Latinx residents heard convention center, they heard detention center. And so just the impact, the unintentional impact of some of policies, I think have resulted in direct deaths within these last few months. And it's unfortunate. I think everybody at the hotel really wanted and wants to serve disproportionately impacted communities better and more, especially Latinx communities. But because of things that are perhaps unintentional consequences of policies, we are a bit hampered in that. But I'm happy to discuss the rollout of the hotel. I will share one more picture. I know we have limited time, but I want to share how we transformed the hotel hallway. Excuse me, technology. If you can see this, you would come off the elevator, and to your left would be normally a hotel hallway, and this was cordoned off on each side. The hallways would be blocked off with plastic, and then you had antechambers, so there was double barriers of plastic doors and ceiling, so that people could don and get in their PPE going in, and then you would stay in the hot zone until you were done, and then you would doff and come out. So we had cold, not hot, not zone elevators for staff before they would go into the COVID zone, and then the residents would enter through service elevators to get up to their room. So I just wanted to make sure that people were aware of the investment that the hotel and everybody went into to really transform it into an isolation site as opposed to a guest serving site.
Wow, thank you, Dr. Moen. That was amazing to hear. Can you hear me? Yeah. So thank you so much for that insight and that amazing overview about the transformation of that. There's a couple of questions that are in the chat box, and one is just to acknowledge the mental health stress that this has certainly imposed on all healthcare workers, but all of you have your own stories about that. And I think that when we're talking on how we respond in any crisis, and certainly the pandemic and COVID is a crisis globally, we figure it out as we go. And Dr. Deepak, you really said that we've never been in this territory to the same extent as we have now. And so one of the things we can think about conceptually is the value and the importance of caring for healthcare workers themselves and their mental health. But early on we heard about the suicide of one of the ER physicians from New York. So how do you anticipate, or what you have, the question is, what kind of impact has mental health had for healthcare workers, and what resources have been available to support healthcare workers during this? And Dr. Kaysen, I'll start with you, and then I'd like to have the rest of you respond.
Yeah, can you hear me? Okay. Yeah, I think that's a very that's a really profound question, and one that I think will be continuously need to stay on the forefront of these discussions, because we like to put up signs and billboards acknowledging the hard work and almost like the superhero kind of mentality about healthcare workers. But in reality, these are just people, everyday people who are doing their jobs, and they're just as susceptible to stress and burnout and all the mental health impacts that these sorts of disaster situations present. So organizations, I think, are recognizing that to some extent, but I'm always advocating on a small level within our department to try to look at that on an individual level. So whether it's trying to work with community partners to assist with childcare, with groceries and food distribution, and we have to acknowledge that some of our employees in these health facilities earn just above minimum wage, and those people need to be treated just the same as anybody else. And so, it's good to have programs that address counseling and provide access to apps such as Headspace. But I think on a structural level, we need to go much more beyond that. I think we're still in the infancy in terms of childcare assistance to families, and in terms of the HR policies, we really need to look at that, because when we tell people to quarantine for 14 days, well, you're not guaranteeing them a stable salary. And in terms of their mental health impact, try to imagine taking care of a family when you're living paycheck to paycheck. And, as providers, we are more sheltered, I think, to some extent. Of course, we experience all of this stress and seeing people suffering to such a significant extent. But I also want to make sure we're not leaving behind people in support services and all the ancillary levels.
Thank you. Dr. Deepak?
Yeah, I think for us, the first thing we did was to make sure that our office staff were all well provided for, because one, they didn't know what to do, and suddenly there was no clinic, and there was no way of communicating. And so we made sure that one, there was no kind of penalties of any kind, and even till today they have a mixture of working virtually, and we have endorsed that for all of them. We have ensured in our department, so we've only worked on this in our department and we haven't done more than that, but we have tried to make sure that everyone has been cared for and nobody has been penalized for being quarantined, and we have encouraged anybody to quarantine themselves even if they felt a little bit sick, so that was the policy to be encouraged. Burnout was very, very, very high and is very high in our department. There's no doubt about it, because we really did and are bearing the brunt. And I would say the people other than us, providers, the nurse practitioners, sorry, I'm in clinic space, so it just keeps going off. The nurse practitioners who took care of the COVID patients so that the house staff would be, did not have to bear the brunt of it. They were the ones who took care of all the COVID patients, and they were really tired. And we were trying to ensure that everyone was taken care of, everyone was getting time off. For our fellows, we changed the schedule. What we were doing even for us providers is that we had a COVID phone call every Tuesday for the policies, but we had a happy hour phone call every Friday where we tried to do a talent show or something else, something to take our mind off COVID and to talk about something non-COVID related, something fun, a new thing that somebody started doing. One of our fellows finished a quilt that she started in residency, something else we tried to showcase. Now, having said all this, this is, as Alex said, we have not, this is all providers and our admin staff, and we have not touched the number of people who've been affected, the number of people in clinic, for example, who were affected, who were deployed to other places, other ancillary staff who are affected, who are still affected, who still are going paycheck to paycheck, and who don't have healthcare services. Now, not only are there no childcare services for them, there was no childcare services for any of us in the primary critical care division, be it fellows, be it attendings. So everyone had to call in people from all over to come and take care of their children so that we could go in and take care of the COVID patients. And one of my co-faculty members, both of them are critical care physicians of the husband and wife. So they had to live separate from their child for 4 months, and they had to live separate from their child who was an infant for 4 months, and they were going and visiting from the window. And they had the parents flow down from Texas to do it. So you can only imagine the kind of mental turmoil. They've just gone back, just a month back to normalcy. So I can't even begin to tell you. And I think it's high time that we took care of childcare, provide childcare in-house, being available, provide groceries, because that was the other thing which was not available, because by the time you go back home, there was no groceries available, there was no milk available. These things, the next time that it comes around, there has to be more planning around all of this, because there wasn't anything available. There was no groceries, there was nothing available. And what we try to do is to look out for each other, and that's all you can do. That's all you can do as a community, is look out for each other and try to help each other and keep up the spirits and know that you're helping, at least helping one person each day.
I think that just have pointed out so well, both of you, the widespread effects of this, and such important ways we need to support one another, and the sense of camaraderie and the teamwork that is essential when you're going through something, when everybody else is also in this mode of isolation. At least there's been some support through your teams together. We have about 1 minute left, and I'd love to hear you offer your insight, Dr. Moen. And you're not, we can't hear you.
Can you hear me now?
Yeah.
Way to squander my minute. So I just want to echo the 24/7 availability. In fact, I had left my family, and as a result of me being up in Baltimore so much, they moved back up to Baltimore with me. But I was in a privileged situation where I had a husband and a partner who could do it, and it hampered our ability to staff. And when part of the reason that I had to be up 24/7 is you know you would have call outs for staff for children or different things, and so then our already taxed staff would become more taxed. And yeah, tempers were short and things were stressed, so we didn't know what we were doing, and it was very intense. But the team work got us through. And I just want to emphasize that the Lord Baltimore Hotel in this isolation site is still present. And as Dr. Deepak said, every single person who goes to that hotel saves so many lives because they are not circulating in society. So I just want to emphasize that and get the word out that it is there, and isolation and distancing is going to be key to us getting through this.
I am just so grateful for the three of you, and I'm so honored to be in colleagues with you, and I applaud all that you are doing and have done, and really hope for your continued sustainability and truly saving lives and many. Thank you so much for all that you've done, and I again applaud you and hope that you are getting the rest that you need, and thank you so much for being a part of this, and I will see you soon. Thank you.
Thank you, everyone.
Yeah. See you. Bye.
Thank you.
Thank you.